All right. Well, just to get us started off today, welcome everybody to our Friday CFAR conference. Today we just a few updates and announcements. So first of all, I just want to call everybody's attention to the email that we got this week about the upcoming, sorry, don't have the actual what it is, but the 40th anniversary of the Bartlett Clinic celebration that is planned for December 5th. It will be both in person and a virtual option with a reception following, and that's going to be in the Armstrong Medical Education Building, which is over close to Jayhawk. So please just be mindful of those communications. I think it should be a really exciting event and day. And then just in terms of our upcoming conferences, so today I'll get to our introductions in a minute, and then next meeting, we have anal cancer screening updates and the clinical workflow, which I know is highly relevant for many of us. So please join us for that with Dr. Abdi, who runs our HRA clinic, Dr. Joyce Jones and Dr. Randy Bornman, who've worked on establishing the clinical workflow to make sure our patients get the care that they need. And then we'll have a Thanksgiving holiday, followed by the week after that when we return with both some Bartlett updates, and we'll do some cases. So again, please forward along any cases you'd like to discuss. The more, the merrier. And just send me an email, or you can send me an email with a secure subject line, or you can send me or you can just send me an email and then send me a chat with any patient information. So with no further ado, I will stop sharing my screen and introduce Dr. Rosen, who's going to give us a talk on a CFAR-sponsored project that was looking at infant feeding guidelines. And we had a talk from Dr. Judy Levison last year about the development and some of the history around how these guidelines were changed. And now today we're going to hear a little bit more of a real world implementation. So I'm very excited to hear and hopefully have some good discussion afterwards. So Dr. Rosen, thank you so much for joining us, and I will give it over to you. That looks perfect. You're in presenter mode.
Fantastic. And thank you again, Dr. Scully, for the invitation to speak. And it's great to see a lot of familiar faces. So for folks who I haven't met before, it's great to see you all here. My name is Greg Rosen. I was faculty at Johns Hopkins for about a year after I finished my PhD in the Department of International Health, and I recently moved over to Brown University, where I'm an assistant professor in internal medicine with a joint appointment in the Department of Epidemiology. Today, I'm excited to return to my CFAR roots at Hopkins and be sharing some hot off the press findings from a rapid qualitative assessment that we led with funding support from the CFAR at Hopkins, to really understand what some of the opportunities and constraints to implementing the revised infant feeding guidelines for persons living with HIV in the United States are. So I will just jump right in. I also took a quick look at folks that were sort of in our Zoom room. So this kind of presentation might be a little different than the kind of clinical presentations that you're used to, but I'm nevertheless hopeful and excited for the conversation that will follow. And hope to make this as digestible methodologically and as relevant to a lot of the clinicians in the room. So I think probably this goes without saying, as many folks here are much more knowledgeable and experts sort of in this space. And in some cases, we're sort of on the front lines of the HIV response early when the pandemic first surfaced. But as sort of a quick orientation reminder to where things were and where things are today. When HIV first emerged, and for about the first 2 decades of the HIV response in the United States, breastfeeding or chest feeding was really strongly discouraged for persons living with HIV. The primary reason being because of the risk of vertical transmission, especially during the first 6 months with exclusive breastfeeding or chest feeding. The availability of safe and reliable alternatives to human milk also made this recommendation a little bit more heavy-handed. The fact that folks could potentially access other feeding options like formula feeding made this recommendation a little bit more potent, especially at the time. And for the first decade or so of the pandemic, there was limited availability and access to agents that could suppress viral replication, like our first and second generation antiretroviral therapy that are widely accessible today. So flash forwarding about 30 years, we now are living in the era of U equals U, or undetectable equals untransmissible. So we have very strong emerging evidence of ART essentially eliminating the risk of HIV transmission. And we also have widespread access to ART for adults and ART prophylaxis for neonates and infants who may have been exposed to HIV during birth in utero or during breastfeeding or chest feeding. And with this evidence has come a very sort of notable risk reduction in vertical transmission of HIV in the context of sustained antiretroviral therapy use. So all of this evidence really prompted the Department of Health and Human Services very recently, actually, so in 2023, to revise or revisit their guidelines for HIV infant feeding to reflect the current evidence and practice. So beyond sort of these guidelines, for many years, a lot of clinicians sort of on the front line and advocates and other service providers had demonstrated that it is safe and possible and effective to provide counseling and support people living with HIV to breast or chest feed safely. And so these new guidelines essentially advocated for a more person or client-centered approach that involved counseling and availing different infant feeding options to persons living with HIV that include breastfeeding or chest feeding, but do not eliminate the possibility of breastfeeding or chest feeding, as was sort of reflected in the earlier guidelines. And I think, as Dr. Scully had alluded to at the top of our discussion for today, the American Academy of Pediatrics, so the AAP, recently revised their recommendation to align with these more recent guidelines. So this is essentially now becoming standardized clinical practice. So the guidelines really, in summary, advocate for greater choice and autonomy in terms of infant feeding practices for persons living with HIV who are taking their HIV medications and are adherent to their medications, have sustained undetectable viral loads, and don't have any other clinical complications, and have access to adequate supports. So these guidelines, of course, are revolutionary in a lot of ways and are a necessary catch-up to many of the option B+ or other strategies that the WHO and other partners globally have really advocated for at least 10 or 15 years at this point. So these are sort of revolutionary guidelines that legitimate a lot of the efforts of many partners globally and persons living with HIV to allow breastfeeding or chest feeding. One of the challenges, of course, with these guidelines is that because they are new recommendations for clinical practice, one of the essential sort of recipes that's part of these guidelines are enhanced counseling. And so with more counseling comes more responsibility for every clinician, and I'm sure many clinicians in the room could relate to this, but there's essentially more now being added to the plate potentially of service providers. And so this really motivated our study that sought to look at prospectively what are some of the facilitators and barriers to implementing these revised guidelines in heterogeneous practice settings in the United States. So we conducted a series of rapid in-depth interviews with both pregnant and postpartum persons living with HIV, as well as different service providers. And we intentionally sampled service providers, not just who were folks who specialized in HIV care, who may have been more on the front lines of advocating for this type of guideline change, but as well as other folks like nutritionists, lactation consultants that don't necessarily specialize in HIV, but will certainly interface with people living with HIV and are going to be responsible or implicated for implementing these new guidelines. And so our work was really guided by pre-planning implementation science frameworks. We leveraged the health equity implementation framework, which you see is illustrated below. And for folks that aren't familiar with this kind of framework, it essentially is an expansion of other sort of multi-level implementation determinant frameworks, but it incorporates elements of health equity. So essentially, it illustrates that at multiple levels, both at the patient level, at the clinical encounter level, sort of at the innovation level, which in this case would be a revised guideline, as well as at the provider and super sort of microstructural level. At all of these levels, there are various determinants that shape the facilitation or implementation of certain practices that will result in either high equity or low equity. And so this framework really helped guide our investigation as we were conducting these in-depth interviews with both patients that would be affected by these guidelines, as well as the providers responsible for delivering these guidelines. So our study team it really was interdisciplinary and included lots of different folks pictured here. So we had public health experts, implementation scientists, HIV physicians, OB-GYNs, pediatrics, neonatologists, lactation consultants, clinical nutritionists. And so really this sort of represents the kind of interdisciplinary team that is really essential for quality science sort of in this space, given that so many different clinical service providers are going to be impacted by these types of guidelines, even if they don't necessarily feel like they would be if they have limited interfacing with people living with HIV. So we conducted 22 interviews in the past year. Some of the characteristics of our participants are shown here. We did 7 interviews with pregnant and postpartum persons living with HIV who were receiving either antepartum or postpartum services from a specialty OB-GYN clinic that works specifically with people living with HIV. And then we conducted in-depth interviews with a variety of service providers listed here that represented various clinical cadres and sort of spanned clinical disciplines. So to just summarize some of our key findings and our key takeaways, one of the sort of facilitators of the revised guidelines was that providers really felt ready and receptive towards the guidelines. And part of this was really shaped by the high demand or the perceived demand from some patients that they really wanted to breast or chest feed in the context of their HIV infection. So one provider mentioned it backs up when we say that we can support women with HIV and breastfeeding their infants. It helps us to be able to show the guidelines and that we are following them. And so another, to sort of emphasize the demand for breastfeeding, one patient mentioned it, I still want to have the experience of connecting with my baby. I'm hopeful and wishing that I can go through the 6-month period with her. So there is clearly, among especially the patient population we interviewed, a high demand or interest or ideation towards breast and chest feeding that really motivated providers to want to implement these guidelines. So the other perception among providers and patients is that this kind of revised guideline creates more equity in the type of feeding practices that could be offered to persons living with or without HIV. So one provider mentioned, I think the sense of normalcy that the guidelines give them, they can know that their babies will be breastfed like other people's babies. And then one patient mentioned, I have to do the right thing. I just want to feed my baby and be able to do what every other normal person does. So clearly, in addition to just having the demand for breastfeeding, being able to sort of normalize breast or chest feeding among persons living with HIV was seen as a major impetus for implementing these guidelines. And so next, the other sort of facilitator, if you will, of implementing these guidelines was the promise of expanded choice and autonomy. And so by this, we mean that this gives both providers and patients greater options or flexibility in terms of what people living with HIV can do in terms of infant feeding. And so one provider mentioned, these are your options, and these are the things we think about with these options. And I think that gives someone a choice and power. I think it's empowering. And so, another patient mentioned, every woman wishes to breastfeed, especially me, who was born with HIV. I never dreamt of even having a kid. But when you see things working out by God's way, then of course I want to breastfeed. And so I think these guidelines really were motivating and inspiring to patients who even made a choice, an informed choice collectively with their providers to not breastfeed in a specific pregnancy. The promise of really just having expanded choice and autonomy was motivating. And so, of course, besides some of the potential facilitators of these guidelines, we also see that the guidelines themselves represented in many ways a tool to destigmatize chest feeding or breastfeeding for persons living with HIV. And so, one patient who recounted a story of having to formula feed one of her babies before these guidelines were released, mentioned having to, tell her mother, I just told my mom that I can't produce more milk and the baby needs formula, because she did not want to sort of disclose to her mother that she was living with HIV, and that was the reason that she couldn't, that she was unable to breast or chest feed. And so I think really these guidelines, as framed by both providers and patients, really give an opportunity to destigmatize and really normalize breast and chest feeding for persons living with HIV. And so one anticipated challenge related to these guidelines, especially in the clinical setting, working more, in the postpartum space, in especially pediatrics, is that there's a level of fragmentation within the way that care is provided that prevents providers from actually being, or prevented from providers from perceiving that they could provide adequate counseling if they were unaware of the parents' virologic status or their adherence to medication. So, for example, one pediatrician mentioned, since I'm not the parent's clinician, I don't have a sense of their risk of being non-adherent with their medication and having a detectable viral load. And so another challenge which a lot of patients also referenced, is sort of this inconsistency in terms of messaging and responses related to the recommendations around breast or chest feeding. So being in a lot of, especially in our US healthcare system, a lot of people living with HIV, in addition to an HIV clinician, will be interfacing with different clinicians in different clinical spaces and hearing different messages or recommendations around the safety of breastfeeding or chest feeding felt discouraging to some patients, and also was a concern expressed by providers. So one provider mentioned, I know there are providers out there that don't know about the guideline change, and that's going to make it more difficult for parents. They're going to hear multiple things from multiple people, not knowing who to believe. And then another patient recounted, you see this one doctor who tells me this, referring to breastfeeding, is the right way. Then another one tells you a different way. It is more confusing and annoying because they are not on the same page. And so this inconsistent messaging around the recommendations created problems and really might have induced mistrust or reticence to make any decision around infant feeding for persons living with HIV, especially in this early rollout period of the guidelines. And so one other element that was particularly salient from these interviews is the ability to quantify risk when it relates to vertical transmission in the context of breast or chest feeding. And so what we mean by this is that because there was even if the risk was negligible, the fact that there was a quantifiable number included in a lot of counseling message, so this number that's less than 1%, the quantification of risk really created a sense of reticence and anxiety for a lot of patients, and even for some providers. So as one provider noted, there are many who are interested and would like to breast or chest feed, but don't want to take that tiny, tiny risk. I think more people would breastfeed if they felt like there wasn't that risk, that it was not zero risk. And then a patient mentioned who actually made a decision to breastfeed. It's a little bit scary because as a mom with this, referring to HIV, I really want to protect my baby at all costs. They told me it was a less than 1% chance for her to be infected, but it's a scary thought. And so really this, even if it's designed to be evidence-based counseling messages, the actual quantification of the risk made some providers reticent to even provide that level of counseling, and also made a lot of parents or people living with HIV reticent to sort of adopt breast or chest feeding as an option, even though it was availed to them in both the prepartum as well as postpartum period. And so to summarize quickly, we saw that despite the presence of provider readiness and patient demand for guidelines that embraced breast or chest feeding for people living with HIV, we noticed that there were several barriers, or we perceived that there were several barriers to guideline implementation. And so counseling really was referenced as sort of a way to address many of these implementation barriers, but the counseling did not necessarily account for other sort of non-clinical or health-related meanings of feeding practices. So the importance of breast or chest feeding beyond just nutrition and immunity for the infant, but also being able to bond with the infant. And so we recommend that, counseling that really recognizes and centers the social meanings of different feeding practices is critical to actually living up to the promise of informed choice that's part of these guidelines. The other sort of recommendation that emerges from this is that the counseling messages themselves need to be tailored to different people. And part of that is making sure that they are linguistically appropriate and understood. And part of why we sort of recommend this is because this issue of a quantifiable or negligible vertical HIV transmission risk felt very mystifying to a lot of patients. And so being able to have messages that specifically demystify when people quantify risk is really critical to living up to the promise of informed choice that these guidelines recommend. And then ultimately, having beyond just folks in this room that are attentive and listening to this presentation and are familiar with these guidelines, but really having other professional associations, healthcare systems, and health agencies like health departments really amplifying ongoing dissemination efforts is going to be critical for creating more visibility and adoption of these guidelines at a much larger scale that promote equity, especially since, as we saw, or as we might expect, a lot of hospital systems, like the ones that many of us practice in, have access to certain resources and are oftentimes sort of more familiar with these guidelines as they're published relative to maybe federally qualified health centers or other nonprofit clinics. And so it's really critical that messaging is disseminated at sort of multiple levels by multiple messengers. And so quickly just want to acknowledge many of the different co-investigators, data collectors, and other researchers that have supported this work all listed here. So specifically, Doctors Audrey Buckland, Susan Gross, Andy Ruff from the School of Public Health, Allison Ogwu, Laura Clark, Mary Glenn Fowler, Chris Golden, Allison Livingston, and Anna Powell from the School of Medicine. And we also, of course, acknowledge the CFAR for their funding support of this work. And thank you all so much for your time. I look forward to continued conversation and dialogue in this space. Thank you.
Well, thanks so much, Dr. Rosen. And that was really a beautiful presentation and just touches on so many aspects of how implementation of guidelines can be complex. And so I guess one question sort of from the, like in terms of implementation of guidelines. So if you take a narrow interpretation of the guidelines, meaning like informed consent discussions and informed choices that are sort of patient-led, is there a, like, I mean, because I feel like the data is easier to gather on whether or not people choose to breastfeed or not. But it is possible that after an informed choice discussion, a patient may choose to not breastfeed. So how do you, like, short of these kinds of like in-depth qualitative studies where you're able to access so much of the motivation, how can you on a broader level, like, do you just look for trends in increasing reported breastfeeding or what's the, do you know what I'm, does that make sense?
Yes, I think Dr. Scully, I think exactly right. I think I understand where you're sort of going with this question. And I think, beyond just trying to look at maybe an EMR where you're sort of looking at what people are choosing, perhaps like longitudinal monitoring that's measuring sort of at each visit what people's intentions are might be even more informative. So beyond just saying this is the practice or like sort of the revealed preference by looking at just action or what people are reporting, there's, I think, an importance to also measure intention with feeding practices, because the intention also captures underlying desires or motivations that may or may not be supported necessarily by, and that could be supported clinically, but it could also be supported socially. So maybe they would like to breastfeed, but they haven't disclosed their status to like their partner, for example. And so they sort of worry about, some implications of that, or they don't feel supported by a family member. They just don't have other adequate supports for breastfeeding or chest feeding. And so I think perhaps thinking about ways of measuring intention is also critically important.
And I think the other thing that just really stuck out to me is this like 1%, and how challenging it is as a human being to like incorporate a percentage risk into decision making. I mean, that's about the same risk that I currently describe to patients for transition to injectable only regimens with cabrolpivirine, based on the clinical trial data of a low but present rate of failure of that approach. And I mean, it's interesting to see how people respond to that. And yet, in this case, also the risk is not only personal, but also is actually for the infant. And so, like, just such a challenging thing for us to action, I guess.
Agreed. And I'm curious, sort of from other folks that do, that have a lot more experience with this counseling, it sort of seems to me that, even just putting any sort of numeric value on the risk itself gives a lot of attention to that risk. And in a lot of ways, there are other elements of risk that sort of exist in people's lives that folks are not sort of like acutely aware of or are not acutely thinking of all the time, but this one sort of feels so salient for people. And even, all the folks we interviewed were cisgender women, and all women were sort of saying, even if I've made the decision to breastfeed and have breastfed in the past, I still think about that risk. Like that is sort of an anxiety for me. And so I think it's important to recognize that, and then how do we come up with counseling strategies or messages that try to, I guess, I don't mean like ignore that risk, but sort of like de-intensify the risk itself, or demystify what that means for people, so it resonates in a way that is, understandable and is not sort of fear inducing, I think, in a lot of ways that when we think of risk, and especially transmission risk, that we're used to hearing.
So I usually hesitate to do this, but I see Dr. Anderson and Dr. Powell are both on the call. And if either of you are in a space where you can unmute, would love to get, and I will scroll through the list and see if there are other people should also feel free to either raise your hand or unmute for questions.
Hi, this is Jean, and thanks, Greg, for this presentation and for your work in this area. And Anna may have some comments as well, but sort of to address, Eileen, a couple of the things you said. One of the things we started noticing several years ago is we have a significant proportion of our OB patients are immigrants from low and middle income countries where breastfeeding is not only the norm, but is recommended by WHO. And that was really one of the early prompts for us to think about this. With the support of Chris Golden and a variety of folks in pediatrics and the legal office and everything, we put together a group to really hash out how we were going to deal with this. And I mean, we have the advantage of having a dedicated program to care for women who are pregnant with HIV. And we start addressing their intentions early in pregnancy, early and regularly. And for those who are interested in breastfeeding later in pregnancy, we actually have a meeting with them, their partner, if they wish, or if that's possible, and between peds and OB to really go over and to assess what their barriers are, because um, some women did not want to take that small risk, and were but their mother-in-law from Zambia was coming, and she didn't know about their HIV. And so we tried to work around a lot of different but assessing what their individual needs are. And I guess one other thing, just on magnitude of risk, we think it is extremely low, but we can't directly correlate risk with U equals U in other settings, because there are cases where we have less information on breast milk virus, and it's not always concordant with plasma virus, as well as the fact that there are varying degrees of um, antiretroviral drug, depending on drug and drug class, perfusion into breast milk. So there are cases where there have been somebody with undetectable viral load who has breastfed and has transmitted. So we hedge a little. We do think it's extremely low, but we hedge a little bit. So it is a struggle to try to convey those things. And I don't know if you have any other, if you're able to.
Hello. Yes, I mean, all of those things. I was just going to chime in and say we've published our protocol, but there's been a big, like, that's a really hot topic on the perinatal guidelines right now. And the CDC had put out a call for applications that to study the state of HIV and breastfeeding in the United States. So there's a group from Colorado that was funded for that, and they're working with the Impact Network to look at individual sites around the US who have women living with HIV who are breastfeeding, to assess qualitatively how they're being counseled, and then to also look at breast milk and the burden of HIV infection within breast milk. So stay tuned.
Well, thank you both. Are there other questions from the group? And I will do again what I shouldn't do, but David Griffith, if you happen to be available to unmute, I will just purposefully call on you as one of the few people who actually takes care of the smaller version of humans, because I think that's an important other side of the conversation. I didn't see it, Allison or.
Yeah, no, it's we have a lot of success with our breastfeeding. It's interesting, you know, here at Hopkins, we do a prolonged prophylaxis in our infants who are breastfeeding. We can continue nevirapine till 4 weeks after breastfeeding. That seems like it's going to come up as one of the more conservative approaches, and I think the new guidelines are going to offer that, but also say that just the standard two weeks of zidovudine prophylaxis would also be an appropriate choice. And so, you know, it does fill me with a little bit of anxiety, because that's what I hear from parents too that choose not to, is even without the number of less than 1%, when it's not zero, I've had a mom say, you know, I didn't have a choice in this, like, this gives me some power and I want to like make a choice that I can actually like know for sure that my baby won't acquire HIV. And so I think even the number, even without that, if there's ever some non-zero risk, it's going to be hard for any parent. I mean, maybe that's just being a parent, is you never feel comfortable with your decision and like you're always second guessing things. So I do think it's a burden that is unfortunate, that a lot of the moms have to bear. But hopefully we do learn more, as Anna was saying. I think it's yeah, as the programs expand and we get more data, I think we will learn more, and that'll be helpful.
Yeah, I think also the idea of U equals U, like in making sure that we like, is it undetectable in breast milk? Is it undetectable for 6 months prior to delivery? Is it like, what are the, you know, because for U equals U, like, again, there are those guidelines about how long you need to be fully suppressed, and whether or not and so even fluctuations that might not seem that important could be playing in there. So that'll be really hopefully exciting to see, because exciting from the perspective of to be able to give people more specific risk information so that they can feel more confident in decision making. But I am going to co-sign maybe that's just parenthood of never being quite sure.
I think one other comment that David sort of alluded to is I mean, it's clear that the lowest risk of transmission period is women who are on drugs at conception and then maintain viral suppression throughout pregnancy and in the postpartum period. I mean, that's clearly, and probably also, though, hopefully the study that Anna referenced will give us the data on will that make it truly more U equals U. So hopefully we will know more soon.
And